Good morning, one and all, and a warm welcome to Drishti this year. Well,
Modern medicine is becoming more and more streamlined and protocol-based day by day. And many of the systemic medical conditions, they have very strict screening as well as follow-up protocols. And these cross-consultation details are becoming more important with respect to medical-legal side also. So as ophthalmologists, we should have a very clear and precise understanding as to what are the toxicities that these drugs produce, when to detect, how to diagnose it early, how to intervene early, and when the patient is to be kept on follow-up. So keeping this in mind, we invite you all to our IC today, that is systemic drug toxicity in ophthalmology, how, when, and when to intervene and how to keep the patient on follow-up. So we are beginning the IC by the introduction of who are the drugs, who are the leading players in this scenario. This talk is going to be given by Dr. Danya V.S., Associate Professor of Ophthalmology, Government Medical College, Ernakulam. Welcome her for a very charming presentation.
Good morning, one and all, and many thanks to KSOS Scientific Committee and Dr. Sindhu for giving me this opportunity. So let us move on to the topic for discussion today, drug toxicity, who are the lead players. Systemic drug-induced ocular toxicity is on the rise as vast number of new drugs are being introduced in medicine. Any drug can cause ocular toxicity. Fortunately, only a minority causes significant adverse effects. Reports of the drug-induced ocular toxicity should be very well documented, and other causes or these side effects must be ruled out to establish the causality. Responsibilities of the physician. The physician should be aware of the potential adverse ocular reaction, and he should inform the patient about the possible risk of their use. And they should also educate them to seek medical help when the symptoms of toxicity occurs. They have to do a baseline visual evaluation before the treatment and also to screen the visual changes periodically for the early detection of the problem. So who are the lead players? Let us discuss about that. And systemic medications play a very significant role in any eye disease, and important to identify the high-risk medication and constantly monitor for the development of any complications. So it is imperative for the ophthalmologist and the physician to work together and go hand in hand for the common goal. What are the common drugs which causes ocular toxicity? Chloroquine, HCQ, ethambutol, topiramate, bisphosphonates, systemic steroids, amiodarone, tamoxifen, erectile dysfunction agents, to name a few. So let us see the name of the drug and the other ocular side effects they produce. Topiramate, as you all know, this is an anticonvulsant drug, causes bilateral acute ankle-closure glaucoma. Chloroquine, HCQ, causes bullseye maculopathy. Tamoxifen, given for cerebrats, can result in crystalline maculopathy. Systemic steroids, we are giving it very commonly, and this leads on to posterior subcapsular cataract. Ethambutol, rifampicin, chloramphenicol leads on to toxic optic neuropathy. Vigabatrin, again an anti-epileptic drug, can result in progressive permanent bilateral concentric visual field defects. Sildenafil and vardenafil erectile dysfunction agent can result in non-arthritic AION. And bisphosphonates given for osteoporosis can lead on to acute anterior uveitis, scleritis and episcleritis. Amiodarone, an antiarrhythmic drug, can result in motor scanatopathy, bilateral AION and anterior subcapsular cataract. And anti-diabetic drugs like rosiglitazone and pioglitazone can result in macular edema. And a few more, digoxin, which is commonly used by the cardiologist, can result in decrease in the intraocular pressure and red-green color blindness. And antidepressants can result in decrease in the accommodation, cycloplegia and dry eye. Statins, again commonly used drug, can lead on to extraocular muscle paralysis, ptosis and diplopia. Isotretinoin, widely used by the dermatologist, can lead on to VIH, papilledema retinotoxicity. And other drugs which can result in benign intracranial hypertension are OCP, sulfa, vitamin A, tetracycline, phenytoin, nitrofurantoin, steroids, to name a few. So let us move on to the drugs which affect the specific parts of the eyeball. Those which affect the tear film which leads on to dry eye are antihistamines, beta blockers, diuretics, niacin, OC pills, antipsychotics and isotretinoin, which leads on to meibomian gland dysfunction. Next, those affecting the conjunctiva which can result in the reversible conjunctivitis include anti-anxiety drugs like diazepam, eltroxona, phenytoin, carbamazepine, isotretinoin, COX-2 inhibitors and pamidronate and alendronate. Those which affect the lungs include corticosteroids, which leads on to PSC, and later anti-subcapsular, which is more commonly seen in children, chlorpromazine, yellowish brown granules and ASC, amiodarone, busulfan, gold, allopurinol, desferrioxamine, and ecodinosin. All these drugs, the dosage and their effects will be dealt with by my fellow speakers. Drugs which leads on to uveitis include rifabutin, which causes acute anti-uveitis, bisphosphonates, pamidronate, alendronate, and cidofovir, which is given for CMV retinitis, again leads on to vitritis and anterior vitritis. Those drugs which affect the retina are anti-malarials, which leads on to bullseye maculopathy, phenothiazine, stamoxifen, crystalline maculopathy, methoxyfluoride, interferon alpha, nicotinic acid, steroids, and rosiglitazone and pioglitazone, which leads on to macular edema. And those which leads on to optic neuropathy include ethambutol, INH, amiodarone, vigabatrin, estrogen, progesterone, which leads on to again optic neuritis, and the sildenafil, vardenafil, non-acrylic AIOL, and linezolid, which causes reversible toxic optic neuropathy. Stevens-Johnson syndrome, as you all know, any drug can result in Stevens-Johnson syndrome, but the common drugs include phenytoin, carbamazepine, phenobarbital, lamotrigine, then allopurinol, penicillin, sulfur drugs, and erythromycin. Rare side effects, extraocular muscle palsy by these drugs, and nystagmus by lithium, diplopia, ptosis, and pseudotumor cerebri, and floppy iris syndrome by tamsulosin. So the take-home message of my talk today is the adverse effect profile of each medication is being evaluated according to the WHO Causality Assessment Guide. It is the role of all healthcare professionals to detect, treat, and educate the public about the adverse reactions to medications as they are an important health problem. And it is also imperative for the ophthalmologist and the physician to work together for this common goal. Thank you.
Thank you, madam, for that crisp compilation of the list of drugs. Moving on to the next talk. This is on what are the anterior segment findings in drug toxicity. The talk will be given by Dr. Sindhu Madam, Associate Professor in Ophthalmology, Government Medical College, Ernakulam.
Good morning, everybody. Today's talk is on anterior segment manifestations of systemic drug toxicity. After a drug molecule enters the systemic circulation, it can reach ocular tissue through the uveal or retinal circulation. The choroid, sclera, and the ciliary body have thin fenestrated walls for drug molecules to pass. The small lipid-soluble molecules pass freely into the chesuma and can further diffuse into the avascular structures such as lens, cornea, and trabecular meshwork. The major accumulation sites of systemic drugs are cornea, lens, and vitreous. Cornea has a permeable endothelium, and the stromal glycosaminoglycans can bind drug molecules, leading to the edema and decreased transparency of the cornea. The drug molecules also bind to the lens protein and photosensitize the lens to UV radiation. Longer the duration of drug in the eye increases the chance of toxicity. Coming to the drugs affecting the cornea, amiodarone, chloroquine and hydroxychloroquine, amantadine, and gold and silver are the most commonest drugs affecting cornea. The most commonest corneal manifestation in drug toxicity is vortex keratopathy or corneal verticillata. It is a fine golden brown opacities form an irregular horizontal line in the lower corneal epithelium of both eyes, similar to that of a common age-related Husserl-Stahl line. Several irregular branching horizontal lines form a pattern resembling the whiskers of a cat. With an increasing number of the branches, a whorled pattern develops centered on the point below the pupil and swelling outwards, usually sparing the limbus. So, amiodarone is the most commonest drug causing vortex keratopathy. Amiodarone is a cardiac antiarrhythmic agent. Higher the dose and the longer the duration of the use, more substantial the corneal changes. Vision is minimally impaired in around 5% of the patients with a loss of single line of Snell lens acuity and mild blurring and halos. The keratopathy reverses on discontinuation of the drug. This is a slow process. Can also cause anterior subcapsular lens deposits and optic neuropathy. Even though amiodarone vortex keratopathy is a bilateral condition, unilateral case also has been reported. Chloroquine and hydroxychloroquine also cause vortex keratopathy. chloroquine, this is drug used in autoimmune connective tissue diseases and in the treatment and prophylaxis of malaria. Unlike chloroquine retinopathy, corneal involvement has no relation with the duration of the drug usage. The changes are usually reversible on cessation of the therapy and sometimes clear despite of continuation of administration. And chlorpromazine is used as a sedative and to treat psychotic mental illness. On long-term therapy may develop subtle diffuse yellow-brown granular deposits in the corneal endothelium, Descemet's membrane and deep stroma. Anterior lens capsule deposits and retinopathy may also seen. Argyrosis is a discoloration of ocular tissue secondary to silver deposits, may be iatrogenic or from an occupational exposure. The keratopathy is characterized by grayish-brown granular deposits in the Descemet's membrane. Conjunctival discoloration may also be seen. Coming to chrysiasis, it's a deposition of gold in the living tissue and typically occurs after prolonged administration. Gold is used in the treatment of rheumatoid arthritis, and a total dose of gold compound usage exceeding 1500 milligram can cause corneal deposits. The signs includes the dust-like or glittering purple granules scattered throughout the epithelium and the stroma, concentrated in the deep layers and the periphery. It is not an indication for cessation of therapy. It may be associated with lens deposits or marginal keratitis. Amantadine is an oral agent used in the treatment of Parkinson's disease and related conditions. Some patients may develop diffuse white punctate opacities that may be associated with epithelial edema. And coming to the drugs affecting the lens, steroids is the main culprit in this. Route of administration of the steroids can be systemic, topical steroids, or nasal route. The resultant opacities are initially posterior subcapsular with subsequent anterior subcapsular involvement. Children are more susceptible than adults. Higher the dose and length of the treatment associated with a greater risk. Early opacity may regress if steroids are discontinued. Sometimes the cataract progression may warrant cataract surgery. Excessive use of topical steroids can also cause posterior subcapsular cataract and secondary glaucoma. Chlorpromazine, gold, and allopurinol are the other drugs affecting lens. Ciliary effusion, topiramate is an anticonvulsant and is also used in the treatment of migraine. It can cause acute angle closure, glaucoma with an associated myopia secondary to ciliocoroidal effusion. Presentation is usually within 1 month of starting the treatment with blurred vision and sometimes halos, ocular pain and redness. Signs include shallowing of the anterior chamber and raised intraocular pressure. The treatment consists of reducing the intraocular pressure and stopping the drug. Prognosis is usually good provided the complication is recognized. So picture showing ciliary effusion with an angle closure glaucoma. The drugs causing uveitis is rifabutin, which is used in the tuberculosis. And signs include acute anterior uveitis associated with the hypopion. The drugs inhibiting metabolism of rifabutin like clarithromycin and fluconazole may increase the risk. Treatment is withdrawal of the drugs. And the pseudofovir is a drug used in cytomegalovirus retinitis in acute AIDS, and it presents as acute anterior uveitis with few cells but marked fibrinous exudates. It may be associated with vitritis. Topical steroids and midratics as the treatment. Drugs causing uveitis, bisphosphonate used in the osteoporosis is the another drug. And systemic administration of fluoroquinolone antibiotics, particularly moxifloxacin, can cause acute pigment dispersion, causing bilateral acute transillumination illumination defects and bilateral acute depigmentation of the iris. It can be associated with other classical symptoms like conjunctival infection, eye pain, blurred vision, temporary ocular hypertonia, fixed and dilated pupils. Thank you, that's all.
Thank you, Dr. Sindhu, for shining the torch into the anterior segment findings brilliantly. Now let us see what is hiding behind. I invite Dr. Manju Abraham, Professor at HOD, Department of Ophthalmology, Government Medical College, Ernakulam, for the talk.
A warm good morning. I'll be presenting about drugs that cause toxicity to the posterior segment of the eye. Now, loss of visual loss in toxicity may be minimal or reversible following early withdrawal of the offending agent. Rarely it is permanent and cause progressive loss of vision. Now, based on the pattern of retinal toxicity, these medications can be grouped as those causing disruption of the retina, those causing crystalline retinopathies, vascular damage, retinal folds, cystoid macular edema, and uveitis. Now, which are the drugs that cause disruption of the RP? We have phenothiazines, chloroquine derivatives, clofazimine, steroid preparations, cisplatin, the newer chemotherapeutic agents like the MEK and the FGFR inhibitors, and antiretroviral therapy. Now, among phenothiazines, thyroidazone and chlorpromazine, they bind to the melanin in the RPE and cause damage to the outer retinal layers. Toxicity is dose dependent. Thyroidazone in doses over 800 milligram and chlorpromazine over 2000 milligram per day is toxic. Fundus in the early stages may be normal or show granular pigment stippling. Later on, you can see nummular areas of RPE loss in the posterior pole, and in the late stages, you can see widespread depigmented areas alternating with hyperpigmented plaques, optic atrophy, and vascular attenuation. But despite cessation of treatment, fundus changes progress due to continued toxicity of the drug. Electrophysiological tests as well as fields are abnormal. Chloroquine derivatives we know are used to treat autoimmune diseases and malaria. Hydroxychloroquine with a better safety profile is preferred over chloroquine. Visual loss is irreversible and continues to progress. The risk factors are it is both dose and duration dependent. Patients with renal diseases and age over 60 years are at increased risk. Now, in the premaculopathy stage, the fundus shows subtle pigment stippling in the macula with loss of foveal reflex. Visual fields, SDOCT, multifocal ERG, and fundus autofluorescence help us to pick up very early stages of toxicity. If the drug is stopped at this stage, vision may return to normal. It progresses on to the bullseye maculopathy, and in the advanced stages, we have marked atrophy of the RPE, pigment clumping, optic atrophy, and attenuated vessels. Baseline screening and then annually after 5 years is required. Clofazimine, used in the treatment of dapsone-resistant leprosy and psoriasis, is toxic over 300 milligram per day, causing bullseye maculopathy. Cisplatin can cause a profound visual loss within 6 weeks of starting treatment. It may present either as an ischemic retinopathy or a macular pigmentary change or macular and optic disc edema. We know that long-term use of steroids can cause central serous retinopathy, and even intravitreal injections of triamcinolone, if given for high doses, can cause outer retinal necrosis. Now, the drugs that cause crystalline retinopathies, the important ones are tamoxifen and nitrofurantoin and canthaxanthin. Tamoxifen, usual dose is 20 milligram, but a daily dose of 180 milligram or a cumulative dose of 100 gram is toxic. Patients with high BMI and dyslipidemia are at higher risk. The fundus changes are a pseudocystic foveal cavitation resembling macular telangiectasia, intraretinal crystalline deposits between the GCL and the IPL, macular edema, and punctate pigmentary changes. SDOCT shows disruption of the outer retinal layers. Hyperreflective lesions are seen in the inner retina. Electrophysiological tests are abnormal. Screening is required at baseline and every year. Now, the drugs that affect the retinal vessels, the main ones are the aminoglycosides, the oral contraceptives, intracameral vancomycin, interferon, and rarely brolucizumab also. Now, an inadvertent injection of massive doses of aminoglycosides can cause an acute vaso-occlusive event, resulting in macular whitening, cotton wool spots, and arteriolar narrowing. The visual loss is profound. Even low doses which are thought to be safe, 100 to 400 microns, can also cause toxicity, but the picture is less severe. Oral contraceptives can cause thromboembolic complications like CRAO and CRVO, but now that the estrogen content within the pill is lesser, the chances of complications are also less. Interferons used in the treatment of hepatitis C and multiple myeloma can present about 4 or 8 weeks after initiation of treatment as an ischemic retinopathy. Vancomycin, rarely an intracameral injection, can cause hemorrhagic occlusive vasculitis within 1 week of administration. The main drugs that cause cystoid macular edema are the taxols, pioglitazone, topiramate, fingolimod, and nicotinic acid. It causes large cystic spaces in the outer retinal layers. It usually resolves with discontinuation of the drug. The drugs that cause retinal folds, these are the sulfur derivatives, acetazolamide, sulfur antibiotics, topiramate, chlorthalidone. A ciliary body swelling or a choroidal effusion causes anterior movement of the iris lens diaphragm. This can cause a vitreous traction on the macula and retinal folds. Quite a large number of drugs cause toxic optic neuropathy. It may be antibiotics like long-term use of ciprofloxacin, chloramphenicol, and linezolid, antimalarials, anti-TB agents, anti-arrhythmic agents, anti-cancer drugs like carboplatin and methotrexate, pseudotumor cerebral picture caused by vitamin A toxicity, long-term steroids, and nalgesic acid. Even vaccines can cause demyelination of the optic nerve. Now, linezolid is an antibiotic used to treat gram-positive bacteria and multi-drug-resistant TB and Mycobacterium avium infections. It is toxic over the dose of 600 milligram per day if given for more than 2 weeks. There is a bilateral fall in vision. The disc is hyperemic, and there is peripapillary nerve fiber swelling. It is if you're planning to give for more than 28 days, check the vision and the fundus monthly. Coming to the anti-TB drugs, ethambutol, can cause bilateral loss of central vision. Fundus is normal. Field shows central scotoma, and OCT of the optic nerve head shows loss of nerve fiber layer. It is both dose and duration dependent toxic, and more in renal dysfunction and elderly patients. INH can also cause loss of vision, optic disc hyperemia, but once the drug is stopped, vision usually improves. Among the cardiac glycosides, digitalis at toxic doses can cause photopsia, xanthopsia, and form visual hallucinations. Amiodarone can cause an insidious and bilateral loss of vision. Patient complains of seeing a blue-green ring around the light. Disc is swollen. Amiodarone can also cause a picture of non-arthritic AION, but here it is acute and unilateral loss of vision. Vision usually improves once you stop the drug. Rarely it can cause an optic disc pallor. Now, to summarize, a careful and detailed medication history is needed, especially if the vision is worsening. You need to know more about the recent updates on toxicity. Retinal imaging helps us in the early detection of even subclinical cases. It is not always possible to reverse the changes, but in most cases, progression can be prevented by cessation of the drug. Thank you.
Thank you, Dr. Manju, for stacking in order such large and diverse number of posterior segment findings in short time. Next, I welcome Dr. Deepa MG, Associate Professor in GMC Ernakulam.
So now that we have seen the anterior and posterior segment findings, let us see what are the things that we are supposed to evaluate and document when a patient is sent to us for a toxicity screening. I would like to thank KSOS Scientific Committee and Dr. Sindhu for giving me this opportunity. Well, the relevant scenarios, we saw a large list of drugs involved, but the most relevant scenarios in which this become important is tuberculosis and patient is on ATT. When the patient is having arthritis, connective tissue disorders, when the patient is on HCQS, chloroquine, then long-term steroids in connective tissue disorders, nephrotic syndrome patients on long-term steroids, then chemotherapy agent-associated toxicities, patients on long-term anti-epileptic drugs, and last I have mentioned about allergic reactions in Stevens-Johnson syndrome. This as such is not a long-term ocular toxicity, but this is somewhere even with a single dose, the drug can cause serious ophthalmology implications, and hence this should always be kept in mind. Now, as always, we start with a good history with due importance to the disease duration, treatment duration, the drugs involved, the dose and duration of each of the drug, the past history to any of these drugs which may not have been properly documented in the medical records, and the other associated diseases that the patient may be having. This can lead to a masquerade of clinical findings as well as a modification of the drug metabolism in the patient's system. In examination part, first and foremost is, as always, visual acuity, which should be documented in each and every visit, and preferably the best correction with glass. Color vision is a very sensitive indicator of early toxicity, especially in ATT patients, and this can manifest even before a visual acuity or field loss occurs. In this also, blue-yellow color loss is more important, and the ideal chart that you have supposed to use is a Farnsworth-Munsell D15 chart. Recording a contrast sensitivity is also ideal with a Pelli-Robson chart. In anterior segment evaluation, we have already seen all the findings. In the cornea, you have to look for various deposits. In the anterior chamber, uveitis, depigmentation and other changes on the iris, ciliary effusion causing angle closure glaucoma, then deposits on the lens. In pupil, look for any changes like an RAPD or an afferent pupillary defect. Well, a fundus evaluation is not recommended as a screening tool of choice, because most of the changes occur later in drug toxicity. But as a part of our mandatory ophthalmology evaluation completion, we always do a fundus evaluation and take special, have us look at the optic disc, look whether it is normal, whether there is hyperemia, temporal pallor, and in macula for mainly parafoveal changes, especially in HCQS toxicity. like bullseye maculopathy and all the findings you already know. Many studies have shown that in Asians, the changes need not be parafoveal. It can be in the extramacular regions and also along the arcades. Recording of IOP is important, especially in patients on long-term steroids, inhalational, topical or dermatological use. In visual fields, in HCQS screening and all, the general protocol is given to be 10-2. But as I already told, the findings can be extramacular. Hence, a 24-2 or 30-2 is also recommended in Asians. In ATT, you can look for central or centrocecal scotomas. Rarely, a bitemporal scotoma or a peripheral field constriction can be noted. While coming to imaging in OCT, a spectral domain OCT is always better because of the better resolution. Look for localized thinning and loss of photoreceptor layers in the parafoveal regions. In optic nerve head, retinal nerve fiber layer thickness, ganglion cell thickness and volume loss is important. Macula, look for the changes of drug toxicity as well as look for any pre-existing macular disease. Fundus autofluorescence is another important investigation that you have to do, which show autofluorescence early, increased autofluorescence early and later dark areas of reduced autofluorescence as the RPE loss occurs later. This gives a topographic view of the damage. Coming to ERG, in central retinal function assessment, a multifocal ERG is better because a full field ERG may be most of the times normal. This gives an objective functional assessment even when there are not many structural changes. The various waveforms N1P1, N2P2 mainly represent the outer retinal function and there can be reduced amplitude seen in areas 1 and 2 which represents the fovea and perifovea respectively. Then VEP is not as such mentioned as a screening protocol tool, but in ethambutol toxicity this is very important. There can be reduced P100 amplitude and latency. And in combination with multifocal ERG, this is said to be an important tool in keeping the patient on screening, whether to look for whether the patient is having reversal of the findings when you stop the drug or whether there is any worsening. So this as such, in combination with multifocal ERG is an important tool for screening and keeping the patient on follow-up. Thank you for your patient listening.
Thank you, Dr. Deepa. That was an enlightening presentation and for clearly defining what all is not to be missed in a patient's and for screening.
Good morning to all. Thank you, KSOS and Dr. Sindhu for this opportunity. And welcome to everyone to Drishti 2023. So let us look into a little bit in detail about anti-tubercular treatment, whether we are doing it right. So we have the 27% of the global TB burden, and we are the major country to have a countrywide national program of against TB. And over the years, our TB program has changed from the tuberculosis control program in 1262 to RNTCP in 1997, that's 1962, and 2016 when it was modified, the RNTCP was modified. And what was the change that was happening? In RNTCP, ethambutol was included in the intensive phase. It was an intermittent regimen without the fixed dose. In 2016 modification, ethambutol was added into the maintenance phase. Daily dosing of ATT was given and a fixed drug combination was now introduced. Now, every treatment has some downside, and therefore, though the historical incidence of ethambutol toxicity was 1 to 2.5%, and it is a dose-dependent toxicity with a recommended starting dose of 15 to 20 milligram per kilogram, in recent years, all of us have seen alarmingly increasing ethambutol toxicity. Now, why did that happen? That is because of these changes that have happened after 2016. This exposes the fixed drug combination for a longer period, now exposes the patient to ethambutol for a longer period, and that is the possible culprit. Now, why did we change to FDC? Compliance will increase. That is why we have changed it to the FDC. But ethambutol toxicity has also increased. Now, according to this, a higher weight band person will have a very high increased cumulative dose of ethambutol, and this increases the ethambutol toxicity. Now, are we all just imagining this, that we are seeing more ethambutol toxicity? Like some TB specialists, when you tell them, they say that no, we are not seeing much. But there are studies now. In 2022, LVP has published the study which showed that over the last 4 years, 16 cases in 2016 to 13 cases cases in 2017, 31 cases in 2018 to 96 cases in 2019. So that is a large increase. But why should we bother? Prevalence is less than 2%. But even then, we have 1.9 million newly diagnosed cases and possibly around 38,000 ethambutol toxicity per year. Is it reversible? No. It was thought to be largely reversible, but all of us now see patients who are not reversible and who do not have full recovery. And therefore, you need early detection and management. How do they present? They can present any time 3 to 6 months after ATT initiation. It is earlier presentation in those who have impaired kidney problem. And typically, it is a bilaterally symmetrical subacute central vision loss. But by the time they become symptomatic, it becomes significant damage. That is why the role of screening is needed. What all can you do? Pupillary reaction has mild role because usually it is symmetrical. Color vision defect, red-green mostly, not more than blue-yellow. Contrast sensitivity reduction, which can be checked in our OPD. Fundus examination, however, is a late change, but still routinely needs to be done. Small peripapillary hemorrhage may be a sign. Hyperemic or edematous disc may be there, and later on pallor. Visual fields, like we have mentioned earlier, generalized reduction in sensitivity in the central field, central or centrocecal scotomas, sometimes bitemporal breakout of the visual field can occur. Can OCT help? Yes. OCT, RNFL and GCC can help in preclinical diagnosis of ethambutol toxicity. So you have seen it is a variable presentation. This is a very typical picture with bilateral disc pallor and centrocecal scotoma on field defects. Subclinical biomarkers, the most important is the OCT, RNFL, change in RNFL thickness, especially in the temporal quadrant, GCC thinning, and in the HFA, when you have a reduction in the visual field index and presence of a visual field defect on the pattern standard deviation plot. Pattern VEP, we cannot do it routinely, but it will show increased latency and decreased amplitude. There was a study done that was evaluating the incidence and indicators of early detection. Though incidence was less than 2%, subclinical damage was seen in 46% of eyes. Therefore, you need a high index of suspicion. Adverse outcome predictors are old age, renal insufficiency, and chronic smoking. And subclinical toxicity group has definitely much higher than those who have actual toxicity. Now, you can ask, the important thing is to warn the patient about this problem and that a change in the quality of vision can occur. Color and contrast difficulty, if they have it, they need to report. And although ophthalmologic evaluation is done, is not routinely told to the patient, we have to increase awareness among the TB specialists so that they do a routine ophthalmology evaluation and then at 2 monthly intervals. And then if you suspect, you need to go ahead with the VEP also. What is the treatment recommendation? It is the first and foremost thing is to stop ethambutol. That is the only thing we can do actually to stop the toxicity. Communicate with the physician. Everything else, neuroprotective agents, vitamins, cyanocobalamin, everything has only an anecdotal role, and IVMP also has no proven benefit in ethambutol toxicity. If after 4 to 6 weeks of stopping ethambutol there is no reversal, we should think that it may be other toxicity also. So INH or linezolid, if the patient is on, then that also should be stopped. And visual outcome is largely variable. We cannot say variable to partial recovery can occur. And sometimes drop in vision and functional parameters will remain permanently. So consensus, mainly high index of suspicion, early detection and cessation of the drug. Look for, you have to educate your physician regarding this problem. Look for subclinical biomarkers and prognostic factors. So probable protocol that we can follow is a functional assessment with visual acuity, color and contrast sensitivity, HFA, anatomical assessment with fundus evaluation, OCT, RNFL and GCC, and if any suspicion, the electrophysiological VEP. Preferably do it at baseline and follow up at least 2 monthly. In our institute, we do it monthly until ethambutol is stopped. And in high-risk cases like elderly and renal disease, even electrophysiological tests can be done after 3 months. One unanswered question that we have is whether we should go back to the flexible regimen. The problem with that is that the compliance will be less and there will be emergence of multi-drug resistant TB. That is why they are reluctant to go back to the old regimen. So that still remains in front of us, what can be done in the larger point of view. But as ophthalmologists, what we can do now is to screen the patients, educate the patients, and educate the physician that this kind of problem is on the rise and they need to be aware of it. Thank you all for your patience here.
Thank you, madam. As madam already mentioned, the number of cases of ethambutol toxicity are on the rise, and many institutions are coming with this, following this protocol strictly, that is having a baseline screening and then a follow-up every 2 months. The most important part here is communicating to the patient about the importance of this, because baseline is sent from the pulmonology department itself, and that is done before initiating ATT. But the follow-up always depends upon how we convince the patient to come for the follow-up. Thank you, ma'am, for that very detailed and enlightening presentation. Next, I invite Dr. Sudha V to talk about HCQS drug toxicity. She is the professor of ophthalmology in Government Medical College, Idiki, and she is a clinician par excellence in medical retina. Welcoming her for the talk.
Good morning to all of you, and thank you, Deepa and Sindhu and the entire Ernakulam team for giving me this opportunity. So my topic was given to me was chloroquine toxicity, but it is not actually chloroquine which is toxic now, it is hydroxychloroquine. And since the speakers have spoken a lot about all these manifestations, I'm not going to go into the detail. I'll be just highlighting some important points. First thing is, what is the dose that is usually given? Now, chloroquine tablet is available at 250 milligram and hydroxychloroquine is available at 200 milligram dose. And the usual given is 200 milligram per day of hydroxychloroquine. Chloroquine is now very much restricted to only few drugs like amoebiasis and malaria, which is actually given as a few short period. Malaria is given once weekly treatment or something. So it's not really a big issue. The issue is when you give it for a long time. That is in collagen vascular disorders. And it had been used as an irrational use in COVID, which is not very useful. But the same thing at the same time, if you know that the cumulative dose of 1,000 grams is supposed to be toxic, and this comes after 7 years. So it is not really a very toxic drug in that sense. But for those who are getting collagen vascular disorders, they will go beyond that 7 years. The other thing important here is that side effects of the eye are later. The side effects of the body come first, so we can detect it early. So things like pruritus, headaches, when the patient comes to you with these side effects or major side effects like cardiac conduction defects, think about this toxicity. And there you can stop before it goes on to become a retinal toxicity. So the other ones are skin hyperpigmentation, cytopenia, and neuromyotoxicity. So ocular toxicity, we don't say 1,000 grams now. We say anything more than 5 milligram per kg per day. But how many of us actually calculate it per day dose? We just give 200 milligram BD. That is the dose usually given. But anyway, if it is 5 milligram per kg per day for hydroxychloroquine and greater than 2.3 milligram per kg per day for chloroquine, it can be toxic. And the toxicity appears at 5 years of use, more than 5 years. And this toxicity is not insignificant. Around 7% people do get toxicity after 5 years and 20% after 20 years. And especially if they have renal failure or there is a use of tamoxifen, or if there is a pre-existing macular disease. Now, why a pre-existing macular disease? That is because we no longer can distinguish what is the problem. So you need to know this pre-existing disease and polymorphisms. So what is the mechanism has already been told to you. It is maybe damaging to the cones or rods, but more likely it is connecting to the RPE and causing damage to RPE. Now, the common one which everybody says is bullseye maculopathy. I'll just like to say something. Before this appears, the patient will give a fact that he is having a central scotoma. So if you're very, very careful, even before this, you can ask the patient. So ask the patient's history. This is a late manifestation. By the time this comes, we are already too late to do anything. So ask the patient every visit if he is having a central scotoma, if he is having any blurring of vision. And this is one of our patients who came with an unidentified visual loss. On fluorescein angiography, you can see those rings. So that is bullseye maculopathy. And most important here would be to do the fields. After all these tests, the fundus photographs, everything, you can see that the most significant is the field. So the field defect is more likely to come first. The symptoms and field defect is more important here. But in Asians, remember, bullseye is not the predominant finding. It is said that this is mainly a Korean study, so we don't really know in India. But they have said that it is a study where the pigmentary changes 8 degrees from the fovea, that is along the arcade and nasal to the disc. So we may get this kind of a change. And here you will see this more on the fundus autofluorescence and the 24-2 field. So 10-2 is not significant here, 24-2 field. But remember, any central defect in a 24-2 field has to be confirmed with a 10-2 field. So once you get a change, confirm it. So 10-2 is necessary, but first do the 24-2 in Asians. So any abnormal, you can get changes, as she said, in the retinal periphery also. There are certain cases because chloroquine or hydroxychloroquine is given as an immunomodulator. It is given for small lung cancer and graft versus host disease in very high doses. So in these kind of patients, you can get an early toxicity even after 10 or 11 months. Other changes I'm not going to go for. You can get old changes like RP. The significant here is not the changes, because by the time changes come, it is too late. So what is the prevention? Now, there are well-defined guidelines the American Academy has told us. So the maximum we've said use is 5 milligram of hydrochloroquine, and chloroquine is 2.3 milligram. And annual screening should begin only after 5 years. But fundus examination within 1 year is important, not to detect toxicity, but to detect if there is some other disease which could confuse the toxic changes. So that is important. It is necessary to do a fundus examination. It is not necessary to do a baseline field test. That is up to you. If that patient has got glaucoma or something else, you can do a field change. But there is no need to do an OCT or a field at the first year. So the test should detect before RPH damage has occurred. So as most important test, after 5 years, we have to do a visual field. And though the standard is 10-2, 30-2 for Asians. Any single spot, repeat the test with the 10-2. SDOCT, multifocal ERG is the standard, but that we don't have most of us. So you can manage with the thing. The point is that if one of the tests is abnormal, you should do a second test. 2 tests abnormal will confirm toxicity, most likely. So another thing, if the patient has a small stature. Now, how this dose is calculated? Initially, it used to be calculated on the ideal body weight. That means a person's weight plus height used to be considered. Now, in that case, small stature people will get toxic. Similarly, an obese person will get more. So that used to be there. Now, it has changed from ideal weight to actual weight, but even actual weight problems will occur, that thin persons may be getting overdoses also. That is also part of it. So anyway, obesity, small stature people may need early screening, and liver or kidney disease, as already said. Tests no longer recommended are color vision. There is no point in doing it. Amsler grid, it is not an optic nerve toxicity. We know damage is occurring. Damage has already occurred by the time these abnormal tests are occurred. So we don't need any of this. Baseline retinal photography, ERG. ERG is a very diffuse thing. So FFA, no need for these invasive tests. Visual field, do the visual field, do them in a regular screening method every year, and you will get the changes. Contiguous points, remember contiguous points in the central area. SDOCT, there will be a flattening of the depression. Now this flying saucer sign is a late sign, we don't really need to do, but basically that is because the foveal depression is flattened and parafoveal changes have occurred, thinning has occurred, so it looks like a flying saucer. But multifocal ERG, if you see those changes, you see that marked area, that is the infranasal quadrant where you get reduced amplitudes of this multifocal ERG. ERG is a diffuse test, but multifocal ERG is for macula. So when you get multifocal ERG, just check the amplitudes in various areas. If the amplitude is down in a particularly contiguous area, that is definite sign. Newer tests are there like microperimetry and adaptive optics. They're very good, but I won't go into that further. Cornea verticillata, she's already said it's a reversible phenomena, so it's not really important. Why is retina not reversible? Because the half-life of chloroquine and hydroxychloroquine is big. So even if you stop, the drug will be in the body. It will take time for excretion. That is why the damage keeps occurring. So you have to stop before that. So let's just for the management, when you are selecting a patient, if it's a non-Asian patient, do a 10-2 field. If it's an Asian patient, do a 24-2 field. If all tests are negative, fine. Just keep repeating the screening. But if they're suggestive, do the second test. Okay, if the second test is also positive, most likely you go in for that, or you can do a multifocal ERG. So you'll have to stop the drug when 2 tests are positive. Then if there's 2 tests are uncertain, still you're not very sure, field changes are there, then you have to go in for a multifocal ERG. And the drug has to be stopped when you see the problem. So that is the most important thing. And as I've already said, earlier the retinopathy is recognized, greater the chance of visual preservation. Thank you so much.
Well, in comparison to ATT, in HCQS, we had more gray areas as to when the screening was to be done. And now the awareness among physicians is also increasing as to the first screening to be done in the first year itself. Initially, it was done after 5 years of starting therapy, but now they are sending more patients. Even before initiating treatment as a baseline evaluation also, they are sending patients. But when the patient comes to us, what are the things that we have to document? That is our confusion. So as Madam mentioned in the initial stages, a fundus evaluation, good fundus evaluation itself is enough. And later on, in the follow-ups after 5 years, we have to give importance, especially to the fields as well as to the imaging. Thank you, ma'am, for that very informative presentation. Now that the talks are over, we are open for any questions or discussions on the same. Mike, please.
Congratulations to a wonderful presentation by everyone. Excellently done. I have a small point to make here. See, I noticed that in all the presentations, there was a lot of emphasis on Asians, right? But I need to make a point here clear that Indians are genotypically not Asians. We are Caucasian. So all those studies, no, it's not a joke. We are Caucasian by genotype, all right? But we may identify ourselves as South Asians. We are not genetically similar to the Asian population. So we cannot extrapolate Asian studies to ourselves. In fact, if we don't have actually Indian studies, it's probably better to go in and compare ourselves with the Western studies, because that is where our gene pool comes from. Thank you.
Thank you, ma'am, for pointing out that very relevant point.
That I have actually already told you, that study is a Korean study. So it's not an Indian study. We don't have studies on it. So you be careful. You do the screening 30-2 and see a finding, you repeat the test on 10-2. So it's very essential. 10-2 is done.
Hi, good morning. It was a very wonderful talk. Just adding on to a small thing, I had a patient yesterday. He had developed bilateral cystoid macular edema after starting on a chemotherapy by docetaxel. It was just a 15 days course that he had completed of docetaxel for CA tongue, and he had developed cystoid macular edema in both eyes. So there are very few studies only regarding this, and we have asked the oncologist to stop it. So the study that is there is a cystoid macular edema in RP patient who was on a docetaxel. So this is one unique thing that I saw yesterday. Thank you.
Thank you, ma'am, for sharing that info.
Good morning. As ma'am rightly pointed out, now physicians are all the more aware and they are sending patients for baseline evaluation before starting HCQS. So suppose we already have a patient who has a bad macula, patient is already a case of advanced glaucoma. How do we go about giving fitness? They are now asking for fitness for starting HCQS.
Yes. Sudha, ma'am, can you HCQS?
That is why baseline investigation is important, because HCQ is itself a life-saving drug. You cannot just tell them not to use it. So you do that baseline investigation and follow it up. That is why repeated things are necessary. When you have a problem which has a macula, you'll have to repeat it every year instead of 5 years. Don't wait for 5 years for the damage to occur. So you know that this is the baseline change. Go on to start hydroxychloroquine. If it is worsening, stop the drug. That's all. The glaucoma does not cause the damage which you are talking about. Where is the damage in visual fields like that? It doesn't come like this concentric, or doesn't come at the 2 to 8. They are typical changes of glaucoma.
Already patient has a central dense photoma in NTG patients?
Yes, that is difficult. In that case, you'll have to tell them that you'll have to change a drug. That is why it is necessary to do the baseline treatment.
Do we have to insist on a multifocal ERG on such patients?
Even
Like,
that
it's
won't
not
help
available
because
everywhere.
multifocal ERG will also reduce in cases of glaucoma. So there you can't say pinpoint that this is due to that. If there is a central scotoma, yes, you'll have to change the drug. But if there is just one or two spots and you consider like that, you can always continue and see. But you have to do it a little earlier, not wait for 5 years for that toxicity to do it every year.
Natasha ma'am, about ATT, can you add something? This usually comes up.
Natasha ma'am, in ethambutol toxicity, is there any chance of recovery with the treating with these supplements like pyridoxine, methylcobalamin, any role?
There is no proven benefit, but we all give, because other toxic optic neuropathies like your tobacco amblyopia, all of that, there is a role for cyanocobalamin, so we can give, but no role for IVMP or anything like that. You can stop the HCQ, put them on supplements and follow up. I just want to add about what, that's all, ma'am. What that was asked before, usually we say that we do not ask them to stop. You just have to say that you have found this. So follow-up of a patient on HCQ will be difficult. If you have found a macular pathology, especially if it is a pathology, say if it is like a mild pathology that you can have baseline, see if it is worsening, then it is okay. But if it is not, if there is a like damaged macula and you are not able to follow, then you can say that in the letter to the physician that this patient has already baseline damage. So you will not be able to recognize toxicity when it occurs. Whether they want to stop HCQ or not is up to the physician. That we don't have to give a recommendation like that. When there is definite evidence of toxicity, you say there is definite evidence of toxicity. Stopping and starting is their they have to do that.
Yeah, but in many situations, they send back and they ask for a definite opinion also. We have had similar situations, especially in ATT. Whether should we continue or should we stop?
I think ATT, no, this was in a situation where it is not toxicity, like you're not able to follow. ATT, we can definitely clearly say if we think that optic nerve is being compromised, we can definitely tell them to stop. The problem with HCQ is that they don't have, from what I understood from the rheumatologist, is that they don't have a drug like HCQ, which they can substitute. And it helps them a lot in immunomodulation. So they are very reluctant to stop HCQs. Again, I would recommend not to tell the patient to stop or start. We would just convey that there is a problem in the eye. I am going to convey this to your physician and your physician will tell you whether you are going to stop or start. But ethambutol toxicity, when it comes, we have to counsel because finally it is the ball is in our court. Now we have to tell them that ethambutol has caused. I've had a lady, she was like 74 years old and she had 1/16 both eyes. So, when she came itself with ethambutol toxicity. And there is no other way except to tell her that this is it. And before we say that optic nerve, especially when they come advanced optic nerve toxicity, I always advise an MRI also because you cannot confirm that it is ethambutol toxicity without having a normal MRI. So do not think that all, might even be a TB complication in the brain. So do not think that any optic atrophy that comes to you is ethambutol toxicity without doing an MRI. That is absolutely essential.
We also had a patient with linezolid, which came with toxic neuropathy, and we stopped it, and then the vision reverted back to 6/9. So is it always like that, or I just wanted to know?
Linezolid toxicity, I'm not very sure, but from ethambutol, it is very variable. I have had patients who have improved to 6/9, 6/6. I've had patients who have remained at 1/60 and not improved at all. In fact, a businessman, and we gave him everything. In fact, we gave IVMP also, though I am saying that it is not recommended. We gave IVMP also because he was so insistent that he can't work without his vision, and it was not very, not in the older age group also. It is a very difficult situation. And I find in our uveitis group, there is a lot of work being done to convey this to the policy makers, that this problem with this regimen is there. It is a definite problem and it needs to be changed. In the last USA, what I understood is that the representation has been given. There have been talks to reduce the duration of the dose of ethambutol. But even now, no decision has come from the government of India. And it is a big problem. There is definite, and the problem is some of the physicians are resistant to it also. They do not recognize that there is an increased incidence, and at least that is my experience in talking to a couple of people, especially in the beginning when we were seeing this. Now they are a little bit more aware. Before that, they would be just no, there is no ethambutol toxicity is what they would say.
And especially in medical college like institutions, at least they are sending routinely. But when it is being started from the periphery and when the patient is on follow-up there, the routine screening is not happening in most cases. And we see at a very later stage.
I'd just like to emphasize to everybody, ATT drug toxicity is now reportable. So please report to the district DMO or whoever it is. There must be in your, if you're working in a medical college, there would be an adverse drug reaction report. The pharmacology department usually deals with that. So it is important that all your drug toxicities are now monitored and as well as reported, because that is the only way we can get the government to convince this. So please make sure that any ATT regimens, any problem you have detected, somewhere it is being reported to the RNTCP people.
Yes.
The district or this thing has made it a rule that it has to be reported. So how you report it is up to you.
There is a physician who is giving the TB will be under the RNTCP, even if he is in the private hospital. So you can ask them to report also. If you have a good rapport with the physician, you can just inquire that the physician has reported. If you have access directly to report, I think directly also you can report. Yeah, that is about 4 to 6 weeks if there is no change in the visual acuity. He said also. Yes, that is also being seen. After the 6 months are complete, they can present even the next 1 or 2 months, they are still at risk.
And I think in such cases, the prognosis is bad, no, madam?
Yes, prognosis is bad. Because they have already got the entire cumulative dose of it.
Case from Medical College Kottayam, we have many cases of ethambutol toxicity, and usually present after 4 or 5 months of start of therapy. And we have a core committees there from district TB center also. We usually report, and we usually stop ethambutol from RNDCP as well as from the pulmonary medicine. But some cases we had some improvement after stopping the therapy. Some cases don't. Usually they are bilateral, defective vision, and RAPD will be there. Some cases we will have a small congested disc, or some cases pallor also. And I think you have to report all these ethambutol toxicity. And we are now doing a research work on that, ethambutol toxicity, how many cases and all. Previously we had given methyl prednisolone. Nowadays we stop that one. And no methyl prednisolone.
Yes, fine. Thank you, ma'am.
Well, thank you. Thank you all for attending the session. Hope this was informative to all of you. Looking forward to seeing you again in other informative sessions. The speakers, can you please stay back for a minute? Sudha ma'am and Natasha ma'am, can you please come forward for a minute?